Good morning to people from US, afternoon to the colleagues living in UK, good evening to colleagues living in India. It's a pleasure to meet you all on the Zoom meeting and discuss one of the most challenging and evolving areas of our practice, which is heart failure. Despite major advances in diagnostic and therapeutics, heart failure continues to be a major cause of morbidity, mortality, and healthcare burden, both globally and in our local practice. I hope this will be a interactive sessions. I welcome you, your insight and experience as we discuss these challenges. And I'm going to review the current definition and classification of heart failure, and then update on pharmacology and device therapy, practical strategies for optimizing the therapy and our patient population. And heart failure is a syndrome, not a disease. It consumes a lot of substantial healthcare resources like hospitalization, OPD visit, GP visit, heart failure nurse visit, cost of drugs, transport, etc. Inflict considerable morbidity and mortality to the patient, adversely affect the quality of life to the patient as well as the carers. Heart failure burden is rising in England, expected to increase by 34% in the next decade. And it's a 6 billion spent in heart failure treatment in 2022-23, 2.4% of the total NHS budget. Aging population, higher prevalence is the reason. Hospital admission cost is around £3,796 per admission. Higher readmission rates, 50% readmission within 3 months. In case length of stay goes up to 14, 15, even 20 days sometimes. Delay in diagnosis and suboptimal management is another reason for the long stay. Advance and improvement therapies and technology is taking the cost of the service, heart failure service. Demand on emergency and acute services, 5% of all the patients coming to the emergency room are with heart failure. And I start with a case. It's a 44-year-old IT employee, traveled to Rajasthan February 25, treated for chest infection. I don't have any other details. Also, he suffers from type 2 diabetes mellitus, and he takes Ayurvedic medications. And I don't know the type of medication and component of all the medications in that. Seen me on 24th of April 25 this year, mainly breathlessness and exertion after 5 to 10 minutes, one flight, and used to sleep with 2 pillows, tests have PND and leg swelling, decreased appetite, both medically ill, and his weight is 63.2 kilogram, and bilateral leg edema, JEP elevated, and BP 140 or 100, pulse 84 per minute, sinus rhythm, normal heart sounds, and reduced basal air entry and bibasal crepitations. And he had a test done before coming and seeing me. LV ejection fraction was 30% with 1 plus mitral regurgitation. Severe pulmonary hypertension, RV systolic pressure was 65. ECG showed poor R wave progression, non-specific T wave changes in the chest leads. Hemoglobin is low, 9.6. Creatinine is high, 3.39. ESR was not raised, 23. He already had a CT coronary calcium scoring, which is 14.6, which is insignificant. This is not this patient because he had an echo done in Bangalore. I didn't have an access to that. This is echo showing clear evidence of cardiomyopathy. You can see the LV is dilated and contracting poorly. It's a mitral leaflet, it's a left atrium, aortic valve, right ventricle. It's LV dilated, contracting poorly. And there are a lot of guidelines available, and it keeps coming every year. And it's a latest one came from American College of Cardiology, 2024, and then focused guidelines came in 2023, 21, and etc. So all the facts which I'm discussing are taken from this. And this is a new heart failure classification. A is a patient at risk of heart failure but without any symptoms. They do have structural heart disease like LVH or even valvular problem, cardiac biomarkers or injury like patients with hypertension, atherosclerosis, diabetes, metabolic syndrome, obesity. They do have biomarkers, exposure to cardiotoxic agents, genetic history of cardiomyopathy. Stage B is like New York Heart Association classification only. Structural heart disease, but no prior or current signs of symptoms of heart failure. There will be ventricular dysfunction, valvular heart disease, raised biomarkers like BNP. Stage C, structural heart disease with prior or current symptoms of heart failure. And stage 4, marked heart failure symptoms that interfere with daily life, the recurrent hospitalization despite attempts to optimize the medical therapy. As I said, New York Heart Association classification is similar, doesn't change at all. And what is the new heart failure in guidelines in the recent years? They're all talking about American mainly guidance directed medical therapy, GDMT. There's the 4 pillars of heart failure drugs. I'll talk about it. There are new drugs, Vesicut and Finerenone, and role of digoxin in heart failure. And if you look at the guidelines of direct medical therapy and principle, initiate and switch the medication, titrate the dose, refer to specialist, care coordination with the other specialists, nurses, etc., and ensuring patients compliance with the medication, specific patient cohort, like black people, their treatment is different than Caucasians and also Indians. And medication cost and access is mainly applicable to the Americans, not in UK patients. Increasing complexity, comorbidities, palliative and hospital care. And heart failure incidence and prevalence in England, which is increased to 2.4% from 2.8% in 2015, it is increasing. And also, incidence also gone up to 4.85% compared to 4.10%, which is increasing every year. You can see the graph which I created here, 2.8, 2.17, 2.28, 2.39, and heart failure in the epidemiology in India is 1.3 to 4.6 million people affected by the heart failure. Annual incidence is around 4.9 to 1.8 million. Estimated mortality at 50 years is 55 years is 50%, worse than a cancer mortality. In hospital mortality is 12.5% before discharge. 90-day mortality is 18%. 1 year mortality is 31%. Readmission rate is around 31%, and 20% of the people in India will be elderly by 2050, which is a high burden to Indian population. Detailed for the heart failure is mainly coronary heart disease is a common cause in UK and Western countries. Hypertension, especially with the heart failure, the preserved ejection fraction, valvular heart disease. Rare causes are pericardial disease, high output state like anemia, Paget's, AV fistula, pregnancy, thyrotoxicosis, and arrhythmias as well. And also toxic damage like heavy metals, iron, hemocirrhosis, copper, Wilson's disease, and medication like cytotoxic drugs like anthracycline, monoclonal antibodies, immunomodulators drugs like interferon, antiarrhythmics, even non-steroidal anti-inflammatory drugs. Radiation therapy also causes myocardial damage and heart failure. Infiltration by amyloidosis, sarcoidosis, which is commonly seen in UK, and Fabry's disease is very rare, which causes LVH in the myocardium, and malignancy also causing infiltration. And I have seen people with a left atrial myxoma presenting with a severe heart failure and atrial fibrillation. Once the myxoma was excised, patient is back to normal self without any treatment at all. Hormones like pregnancy, pre and postmortem cardiomyopathy, thyroid disease, acromegaly, diabetes, diabetic cardiomyopathy, nutrition mainly thiamine, AIDS, malnutrition, and diverse genomes like all cardiomyopathies, arrhythmogenic right ventricular cardiomyopathy, laminopathies, and muscular dystrophy. These are the common causes in the West. And I come to India, it's totally different. Rheumatic heart disease is the commonest cause of heart failure in India, followed by ischemic heart disease. These two is around 68%. Rest are really very small percentage, and around 10% of the hypertension, dilated cardiomyopathy, congenital heart disease around 6%, and total it's 100. And younger versus old people in India, 58.7% are younger, some compared to old people get more heart failure than the younger population. Younger age group, male more commonly develop heart failure compared to women, and adults, old people, all equal 50-50. Diabetes is more prevalent in India. Basic investigations. All we do the full blood count, urine electrolytes, LFT, TFT, sugar, HbA1c, ferritin level. Also, one should consider thiamine. Now, it's allowed to do NT-proBNP routinely, and 12 BDs is very important, and halter implantal loop recorder if they got a palpitations, chest X-ray, echocardiogram, mainly transthoracic echocardiogram. If needed, they go for a TOE and stress echo, and CMR with the cadolinium, and RNA Mogascan, CT, calcium scoring, CT coronary angiogram, right heart catheterization, endomyocardial biopsy, etc. But biopsy is not considered nowadays for a diagnosis of cardiomyopathies, and it's a clinical diagnosis. And CMR really is a very good investigation tool to confirm the diagnosis of cardiomyopathy nowadays. And if you look at the classification, two type, three type definition in a heart failure with a reduced ejection fraction, 50%. With a preserved ejection fraction is 36%. They have a normal EF. And in between, uncertain mid-range heart failure is 14%. All will have symptoms of heart failure, and ejection fraction is variable, less than 40, 41 to 49, more than normal. And apart from that, if you got a heart failure preserved ejection fraction, they should have an objective evidence of cardiac anatomy, functional abnormality consists of the presence of LV diastolic dysfunction, raised LV filling pressure, including raised BNP. And management of acute heart failure is complex slide. I don't want to talk about it there. And when they come to the ER, initially take a brief history, examination quickly, assess oxygen saturation vitals like pulse, BP, saturation should have a 93% or more oxygen saturation. If not, try with a nasal cannula for oxygen or use oxygen mask, BiPAP, even ventilation. Usually we give IV diuretics. Classics in India they don't give high dose diuretics, but in UK we give around 40 to 80 milligram IV diuretics. If necessary, if they got a BP high, IV nitroglycerin as well. But if they got a hypertension, they have to use IV inotropes, and also prevent deep vein thrombosis, pulmonary embolism. We have to use slow molecular weight heparin. Investigation, as I mentioned already, blood gases, full blood count, electrolytes, troponin, NT-PNP, chest X-ray, ECG, echo, etc. Once you establish the diagnosis, transfer the patient to CCU under the cardiologist, and you investigate them, treat the etiology and the precipitating factors. What are the drugs used for the heart failure? There's the four pillars of heart failure currently. One is the beta blocker, other one is RNA, Entresto in UK, mineralocorticoid receptor antagonist, spironolactone, SGLT2 inhibitors, EMPA, DAPA, sotagliflozin. These are the drugs used in the trials. They should use these drugs for heart failure patient. Also, we can use ivermectin. The heart rate is still high in spite of beta or adequate dose of beta blocker, digoxin, and the new drugs like phenylalanine and vericiguat, also new drugs. We'll talk about it later. And once the patient is admitted, you should really achieve the guidance-driven medical therapy. All the four drugs, 50% of target dose should be before discharge, and then 100% target or tolerable dose by 2 weeks. And heart failure nurse or the cardiologist can titrate the dose by weekly, bi-weekly review in the hospital and the community. By doing that, it reduces the symptoms, improve the quality of life, and reduces the risk of 180 days all cause of death and readmission rate. And these are the three drugs beta blocker licensed to use in heart failure. And dose is, I can put the dose, you all know the dose, I don't have to go through it again. Always try to titrate the dose to the maximum tolerable dose, 10 milligram bisoprolol, 25 milligram for carvedilol twice daily if they are less than 85, and 50 milligram more than 85. Metoprolol is 200 milligram maximum dose. Metoprolol is the first drug used in heart failure in Scandinavian countries. In Sweden, they gave the drug to one patient as experimental dose and found to be very effective. Then only the beta blocker was found to be very useful in treating the heart failure. And RNA is other drugs, which is a paradigm study. I was one of the principal investigators in England, which is the Entresto. It is used with a background good guidance-driven medical therapy for heart failure in the place of ACE inhibitors or ARB, which is very good drug used in functional class 2 and 4. And Entresto is a drug in UK. In India, there's a multiple drugs are available. Sidmas, Thymida, Asamarda, all the drugs are available. Maximum dose 100 to 200 milligram. And UK, the Entresto is about 100 milligram, 200 milligram again per day. And could be given BD dose. Both are BD dose. And SGLT inhibitors in heart failure reduce ejection fraction. They should have a EF of 40% with or without diabetes. Functional class 2 to 4 heart failure. Administered in conjunction with background other medications. Increase urinary glucose and sodium excretion, by which the fluid loss and so that it reduces the plasma volume. Pre and after load is reduced. Improve the myocardial metabolism and efficiency. Improve the renal function and clearly indicate in people with renal function as well. And certain cautions needed. Overall provide both hemodynamic and metabolic benefits. And these are the three drugs used for heart failure in SGLT2 inhibitors: dapagliflozin, empagliflozin, sotagliflozin. And this is OD dose and maximum 10 milligram DAPA and EMPA, 400 milligram sotagliflozin. Caution with a EGFR of 25 ml per minute, and empagliflozin is not a contraindication in CKD, could be used. And also, if it diffuse fibrosis regression, particularly in heart failure with preserved ejection fraction and diabetic cardiomyopathy, where if you look at the MRI, these people do develop fibrosis of the myocardium, and it will cause regression of the myocardium. By that, it translates into durable clinical benefit. Remains an open question. Clinical evidence supporting the role of SGLT inhibitors as modulators of cardiac fibrosis across diverse cardiovascular disease. And mineralocorticoid receptor antagonist, that spironolactone, eplerenone. I use commonly spironolactone because that's the cheapest drug, very well used. And common side effects are spironolactone, loss of libido, target dose are 25 to 50 milligram. In those people, I use eplerenone and 25 milligram up to 50 milligram once daily. Again, we have to be very careful with a reduced ejection fraction, EGFR of 30 ml per minute, and also watch for hyperkalemia. in this group of people for a regular checking of urine electrolyte. And those people who already given all four pillars of heart failure like beta blocker and RNA and SGLT2 receptor antagonist, mineralocorticoid receptor antagonist, then in spite of that they have the problem, and they can use hydrolysine and isosorbide dinitrate or combination of these two drugs. It's called isoleucine in India. Fixed dose. It is available in the UK as well. Isosorbide dinitrate 20 milligram, hydrolysine 37.5 milligram, and start with one tablet 3 times a day, can up to go to 2 tablets 3 times a day. And I do use sometimes isosorbide mononitrate as well, 30 milligram up to 120 milligram, and but no trial evidence for that. And ivapridine is another drug, and indication is mainly LV ejection fraction should be less than 35% on maximum tolerable dose of beta blocker. And in spite of that, if the heart rate is 70, then patient should be on sinus rhythm and the resting heart rate should be more than 70, then we should consider this medication as add-on therapy. And also indication in 1 to 3, New York Heart Association 2 to 3 heart failure. It's pure heart rate reducing agent. Action is via sinus node. They got a lot of atrial ectopic, atrial fibrillation, flutter. It's contraindicated. No point in giving ivapridine in this group of people. Its dose is 2.5 milligrams, starts with single dose, twice daily, can go up to 7.5 milligram maximum dose. Target the heart rate around 50 to 60 beats per minute. That should be the aim of adding ivapridine. Versicot, which is a new drug, it's came in the market in 2020. It is soluble quinolate cyclase stimulator, increases the nitrous oxide signaling, leading to increased cGMP level that decreases the vascular stone and then causes vasodilation, decreases the cardiac remodeling, improve the endothelial myocardial function, improve the cardiac function, reduce the hospitalization. EF should be less than 45%. All should have a maximum tolerable guidance-derived medical therapy. Then, if the patient is still symptomatic with a heart failure, despite all the four drugs, then this should be considered. And contraindication, patient with a concomitant use of similar drugs, pregnancy, patient's anemia, caution is needed. Hypertension, you have to be careful in using this drug. EGFR 15 ml, you have to be careful. And if you look at the management of mid-range ejection fraction, heart failure 40 to 50% ejection fraction, all should receive diuretics, class 1 indication, and all should receive any one of these SGLT2 receptor antagonists. The rest were class 2B in indications because you can use ARB or RNA, MRA, or beta blocker, even vesicle. But these are the drugs, not really one or two trials shows benefit, not 100% beneficial. So you have to be careful when you use these other drugs which is in the yellow or maroon color. And also this dapagliflozin, M4, sort everything, reduces the hospital admission and death rate as well. Vesicle in heart failure mid-range ejection fraction, starting dose is 2.5 milligram once daily, go up to 10 milligram once daily. And now we go to definition of diastolic heart failure, which is a heart failure with a preserved ejection fraction. They do have symptoms and signs of classical heart failure. They do have raised BNP. Ejection fraction will be normal. Objective evidence of cardiac structural and functional abnormality like LV diastolic dysfunction will be there. Left atrium will be dilated. LV mass will be high, like due to left ventricular hypertrophy. LV and diastolic pressure will be high. Right ventricular systolic pressure also high. And as I said, elevated pro-BNP. which is elderly people, it go up to 500 to 1000. And they should have more than that to say they got a heart failure. And this is the echocardiographic evidence. It's normal, E wave, A wave, and this will be different format. I don't want to go through that, all those parameters by which we calculate the whether I got a heart failure with a preserved ejection fraction or not. And prevalence is around 54%, and incidence is 1.1 to 5.45% in the general population. And prevalence has increased over the last 2 decades because older population, more diagnostic tool, mainly the echocardiogram, and predominantly affect the elderly people above the age of 65 years and hypertensive women. Coexisting CV risk factors like obesity, coronary artery disease, diabetes, AF, hyperlipidemia are common in this group of people. And if you look at why we got treat preserved ejection fraction and reduced ejection fraction equally, because both has got high level of mortality, and only you can see the graph, and respective mortality rates are 29% with ejection fraction, low ejection fraction, and 32% with normal ejection fraction. And so it is more or less same, only about 3% difference between the low ejection fraction and normal ejection fraction. So heart failure is preserved is associated with significant morbidity and mortality, despite having slightly higher survival rate compared to the heart failure with reduced ejection fraction. Management of heart failure with preserved ejection fraction, again, fluid overload should be treated with the diuretics, mainly loop diuretics, and this DAFA-M for SGLT2 receptor antagonist, reduce the hospital admission and death rate, treatment of the etiology, cardiovascular and non-cardiovascular morbidities, comorbidities should be treated. Again, what are the comorbidities? High BP should be controlled, improve symptoms, reduce hospitalization, reduce the congestion, diuretic, symptomatic relief, reduce hospitalization by SGLT2 receptor inhibitors, strongest recent evidence. Manage comorbidities like atrial fibrillation, hypertension, diabetes, CKD, target underlying cause, and improve the LV function with rate control and blood pressure control, etc., using beta blocker and calcium channel blockers. So you have to treat the etiology of the cardiovascular diseases and non-cardiovascular comorbidities like diabetes, etc. And role of digoxin in heart failure. This is only orally available inotropes, and which is increases the calcium metabolism and increases the contractility of the left ventricle, reduces sympathetic tone, and by which reduces enhance the vagal tone that reduces the heart rate in sinus rhythm, improve the ventricular function. And heart rate with a reduced EF despite optimal medical therapy, using this digoxin reduces the hospitalization. Atrial fibrillation is used for heart failure with rate control therapy, and when beta blocker is unsuitable or in combination as well. So digoxin is mainly used in high risk group. In spite of the medical therapy, they used to have symptoms in spite of adequate medical therapy. And trial is the one came in 1997, showed clearly reduced the hospitalization by 28%, but no mortality benefit at all. Optimal serum level will be less than 1 nanogram per ml. Contraindication is AV block, severe bradycardia, CKD. We can use it. That's not absolute contraindication, but we have to monitor the digoxin level. We have to be careful with the hypokalemia, hypomagnesemia, and hypercalcemia, drug interaction, amiodarone, verapamil. So when you use this drug, you got to check the digoxin level on a frequent basis whenever necessary, especially when the patient develops any complications. And Penirinone. Penirinone is a new drug. It's a new selective non-steroidal MRA drug tested in 2 trials in patients with diabetic CKD and is recommended for the prevention of heart failure, hospitalization in patients with CKD and type 2 diabetes mellitus. It's proven to be beneficial and similar action like MRA, evidence mainly in diabetes with the CKD patients, low lipocity, less tissue accumulation, reduce endocrine side effects like less gynecomastia, menstrual irregularity, caution, monitor potassium, avoid people with a low EGFR. 10 milligram starting dose can go up to 20 milligram. So, heart failure with diabetes and CKD, SGLT inhibitors is class 1 indication. Penirinone is a class 1 indication. That means a lot of evidence on using these 2 drugs in patient with a heart failure, with diabetes, with CKD. And iron deficiency anemia in heart failure, which is a common problem. They prove they got iron deficiency, then is recommended intravenous iron supplement. And both reduce ejection fraction and mid-range ejection fraction, elevate the heart failure symptoms and improve the quality of life. Intravenous iron supplement, ferric carbomaltase or ferric derisomer maltase should be considered in symptomatic patients with reduced ejection fraction and iron deficiency, reduce the risk of hospitalization with heart failure patients. Sometimes patients will have more symptoms of heart failure in spite of adequate guidance-derived medical therapy. So in the situation, we had to continue the medication for 3 months, and if the patient did not improve, then you had to consider CRT, cardiac resynchronization therapy, either with a defibrillator or pacing. In this case, there are 3 wires rather than 2 wires going to the heart, one to the apex of the right ventricle, one the appendage of the right atrium, one through the coronary sinus going to the lateral aspect of the left ventricle. So you can see one wire atrial lead and ventricular lead, another wire going through the coronary sinus to the lateral part of the left ventricle. So patient should have symptoms, New York Heart Association 2 to 4, and best outcome will be always patient with a complete left bundle branch block with sinus rhythm, and the QRS duration should be more than 150 milliseconds. That's a class 1 indication. If the QRS duration is less than 150 in sinus rhythm with LBB, then it should be class 2B. And who should receive defibrillator? Who should receive pacemaker therapy? CRT D, that means defibrillator, will be given to those patients whose lifespan is more than 1 year. But people who got less than 1 year survival rate, then they'll be given only CRTP, pacing. And other option is patient have a ventricular assist device, which can be biventricular or left ventricular assist device. Biventricular device, you connect the conduit from the right ventricle to the pulmonary artery and left ventricle to the aorta. That's a biventricular. If you go for a left ventricular assist device, the device will be connected to the left ventricular apex and connected to the aorta. The pump will be controlled from outside with a battery-driven device, and battery backup one outside your body and are connected to the left ventricular assist device. And as you know that people above the age of 65 are not eligible to have a LVAC or heart transplantation. And this is the annual report of the heart transplantation in the NHS UK. Report from 1st April 2015 to 31st March 2025. And you can see that in 2016, the 248 patients had a heart transplant. It went up to 350 and then slowly came down, and then 308 for 2025. And if you look at the region where they get the most heart transplantation, it's mainly Yorkshire, up about 25, M25, and that goes up to Scotland. And then also south of England, some people, some area like, Brighton and East Sussex and etc. be the going for the heart transplantation. And if you look at the etiology of the heart transplantation, and cardiomyopathy is the most common reason for the transplantation, 396. Next is congenital heart disease, 40%, and then coronary heart disease, 71 people, and others, 31 people. So total 538. And if you look at the active transplantation waiting list, adults are 269 are waiting, pediatric 39, multi-organ around 5 people are waiting. Total 319 people are waiting for the heart transplantation. Survival rate and at 1 year is 89% and at 5 years is 74%. And that's a good, very good outcome. Heart transplant in India, and first transplantation was done in AIMS in 1994. Approximately 1,300 transplants are done by 2023. Average is 200 to 240 transplants per year in India. Main centers are Chennai, Delhi, Mumbai, Hyderabad, and Bangalore. And 1 year survival is 64% in India, and now gone up to 85% recent series. 5 year survival is 70 to 75%, approaching global standards. And 10 year survival, 50% limited diet, long term follow, because here people don't come and see the doctors regularly. There's an issue with the attendance and follow up, etc. And mortality is a rejection, infection, cross vasculopathy, and also poor compliance of drugs as well. Very important part, because patient cannot afford to have the drugs, so they don't take the medication regularly. Improved outcomes, better donor management, and immunosuppression. And this data came from NOTO, which is a National Organ and Tissue Transplant Organization. And Indian versus global heart transplant outcomes. You can see international standards 1 year 80 to 90%, India 80 to 85%, IU is 72 to 75%, here 5 year is 70 to 75%, 10 year 50%, long term data is missing, and in India not really that many publications. And according to the note or registry, India is nearing international survival rate. So organ availability remains limited in India, but Tamil Nadu is doing much better than the rest of the states in organ donation. The government is really honoring these donors, and also they created a name board in the Madras GH, and where all the donors' names are added in the list, and need stronger national registry follow-up data, and issues like DNA, compliance with medication, cost of medication, family support is very important. Increasing awareness at donor program, poor data collection, outcome not reported by everyone. Not many outcome data is published, and I Googled it. And why the patient must be referred to a cardiologist? As it's happening for the past 15 years. A lot of studies have shown that all the patients with a cardiologist should be referred to the cardiologist for heart failure. They make accurate diagnosis and classification. And also they consider doing appropriate investigation like uh, MRA and coronary assessment, ensuring classification, treatment, expert medication management, dose adjustment, early detection of deterioration, and advanced therapies like CRT, ICD, LV, LVAC, heart transplant, multidisciplinary team coordination with the nurses, dietitian, physio rehabilitation, palliative care, pharmacist, regular follow-up and prognostication, monitor the progression of the disease clinically with NT-proBNP and echocardiogram, and these are the evidence and since 2019 and earlier onwards, all the guidelines they do recommend in 2022-21 is the European Society that all the patients should be under the cardiologist. And heart failure nurse, why we should refer the patients to the heart failure nurse? They are very good in diagnosing and management of heart failure patient. Treatment, prescription, and monitoring is very important. They titrate the dose, educate the patient, counsel the patient and the caregivers, and doctors do not have enough time to do this, and they are very good. They spend a lot of time with every heart failure patient. Lifestyle prescription like diet, exercise, monitoring, psychological support is given by them. Care coordination with the team. They are the uh, primary role is they talk to the patient, talk to the appropriate cardiologist, and also palliative care team if needed, physiotherapy, etc., rehabilitation team, and genetic testing, palliative end of life counseling, etc. And what we should do, why is this patient developing heart failure? And what we should do with a heart failure patient, investigate and treatment of ATR is very important. They got a coronary artery disease, they all should have an angiogram. They should undergo appropriate intervention like angioplasty or coronary artery bypass surgery, which will improve the LV function, prevent heart failure. Again, valvular heart disease like valve surgery, if it is indicated, and mitral valvotomy, TAVI, aortic valve replacement, valve replacement. Also, if they got a mitral regurgitation in elderly, they get mitral clip, they use it. And so that they reduces the regurgitation, significantly improve the quality of life. And congenital heart disease should be treated appropriately. Pericardial disease causing heart failure should have pericardectomy. Arrhythmia and rhythm control is important because if you don't treat the rhythm, if the heart rate is more than 120, 130 for more than a year or more, they do develop arrhythmia-induced cardiomyopathy. So you should convert them into sinus rhythm if at all possible. Consider pacing, ablation, cardiomyopathy. Family screening is very important and that will predict who is going to develop cardiomyopathy. Pulmonary disease, mainly they do develop right heart failure. Right heart failure is very, very difficult to treat, and because they do have no drugs at the moment available except preload reducing agent like isosorbate, mononitrate, dinitrate, but I use a lot of diuretics and also try to use SGLT. And but pulmonary hypertension, which is secondary, we don't use this prostacyclin inhibitors, and that's only indicated for primary pulmonary hypertension. For India, they do use it for any pulmonary hypertension. This Viagra is commonly used. I don't know how they are justifying that, but that's the common use. And obstructive sleep apnea is one of the things which is easily treatable, and they should then investigate by the sleep study and should have a BiPAP and drugs, anthracycline, cocaine, steroids, alcohol, infection, infiltrative heart disease like like Guy's disease and sarcoidosis and Fabry's and and amyloidosis, diabetes, avoid glitter zones, control of hypertension, diabetes, stop smoking, and problem with the aging population in UK. comorbidities. A lot of elderly people have multiple problems and very difficult to address each and every one. And poor mobility, arthritis, CVA, and angina, heart failure, different edema, poor treatment, falls due to low BP, partial hypertension, arrhythmias. Heredity is a very common problem in the world, people. Memory loss is very important because they don't know what drugs they are taking. They don't know how to monitor the vital signs. And drug intolerance and interactions because of the polypharmacy. We have to be careful what we are giving to these people. Poor drug compliance. Anticoagulation is also very difficult to give these old people like AF and LV thrombus, etc. So we have to be very careful in treating the elderly people in UK overall. Patient education is very important. So you have to educate the patient, daily weight monitoring, access to the heart failure nurse. If the patient gain weight very quickly, within few days they gain around 2 to 3 kilograms, then they should contact the heart failure nurse or the cardiologist. And so that they will assess the patient and then adjust the treatment like increasing the diuretics, etc. Salt and fluid restriction very important. And telemedicine is now very commonly used in UK. All my heart failure nurses are given a tablet by which they communicate with the hospital about the weight and vital signs every day. I'm monitoring the full blood count, electrolytes, urea, etc. NICE recommends monitoring the NT-proBNP levels regularly and consider vaccination, compliance with medication, very important. And I do have a monthly MDT when I was in UK with a cardiologist, palliative care team, heart failure nurses. I used to have 4 nurses, 2 in the hospital, 2 in the community, physiotherapists, dietitian, occasionally physiologists, psychologists, and pharmacists. Patient education, titrate the maximum tolerable dose within 2 to 3 months. Repeat echocardiogram once the patient is stabilized, say at 3 months' time. No point in keep repeating the echo and every time when they see the doctor. And studies showed reducing or stopping the guidance derived medical therapy often results in recurrence of heart failure. So close and frequent monitoring is needed. I have seen people, and a couple of people when I left them for 1 day treatment, and after that I started reducing the dose. Then they gone back to heart failure again. So nowadays I don't really stop the medication. Tell them continue the same medication except diuretics. I tell them not to take the diuretics. And you look at the mortality at 1 year, 10 to 15%, 50% at 5 years. Look at and in New York Heart Association 2, sudden death is 64%. But when they come to NIH 4, then sudden death is 33%, and terminal heart failure is 56%. More than 80% of the 90% die of end-stage heart failure along with sudden death. And also, each admission when they come, they're out, the chance of getting destroyed will be reduced. And that's very important not to come into the hospital at all, if at all possible. And there's infection in people with heart failure is a overlooked cause of adverse outcome. Infection is a leading cause of hospitalization and death in people with heart failure. Multiple morbidity, frailty, chronic inflammation, suboptimal vaccine response may contribute to the increased infection incidence and worse outcome following an infection event. And even in the absence of typical signs like tachycardia and pyrexia, management should prioritize infection prevention, early detection, timely treatment. Further research is needed, better understanding of the underlying mechanism and infection prevention. And what happened to my 44-year-old IT employee? And after my treatment, I did give the Entresto. I gave isoleucine, which is isosorbate mononite, dinitrate, and hydralazine, ivaprodine. Because he developed bronchitis, I had to stop the beta blocker dapagliflozin, glycoside, and rosuvastatin, and no signs of heart failure. Echo normal function. HbA1c was very well controlled. Creatinine is still hovering around 3. Hemoglobin is 9.1. EGFR is 24. He is under the care of nephrologist and cardiologist. I felt that his heart failure etiology is due to uh, due to infection and very unlikely due to heart cardiac and diabetes mellitus. And because this is that same patient echocardiogram, you can see the LV is normal and trivial MR. LA is a cross cut of the LV, a cross section and normal function, and the long axis view and four chamber view, LV, RV, RA, LA. And LA is bit dilated, but LV is normal function. So his etiology is heart failure is probably infection, probably some element of diabetes as well, but renal dysfunction is due to poor control of diabetes earlier with Ayurvedic medication. He is under the care of diabetologist, and so under me as well as a nephrologist, and so both are managing, and probably he may need early renal transplant or dialysis if his creatinine keep creeping up. And this is a evidence-based therapy, and yes, Arnie here, and then we give this hydrolysin isosorbate mononitrate, beta blocker, ivaprodine, and injection IV in iron therapy, MRSA, MRA like spironolactone and eplerenone, SGLT2 inhibitors, and if necessary, oral anticoagulant, antiarrhythmics, and flu jab, single pneumococcal vaccination, had antiplatelet and statin. They got a fluid overload in spite of loop diuretics. Consider metalazone, which is a very good thiazide diuretics, which get the fluid out very quickly. Add digoxin as well. Those people who is in atrial fibrillation, whose heart rate is still high in spite of adequate dose of beta blocker. And so very important, self-care, and stop excess salt in the diet, stop drinking alcohol, no smoking, exercise, walking, and daily monitor the weight, self-maintenance of the heart failure, and future is artificial intelligence. And advice from the family friends. People Google the about their illness and telemedicine. They come to the doctor with all sort of diagnoses and driving the doctor mad. And they all come ask me so many questions about their illness, and I have to explain to them patiently, otherwise they won't be coming back to you. And it's not a thing. They go to some people who don't know how to manage the heart failure. So I like enjoying these people with heart failure, and I'm happy to see them on a regular basis every 2 to 3 months. And thank you very much.